A clicker?
Wow, it took my mask off.
I think so. Yeah, I think DT did that. What are you talking about?
Renu's gonna go after you talk about advances. I'll talk about like so let's talk about
Okay.
intermediate advances. The talk is supposed to be changing approaches.
Yeah. Okay.
We're doing intermediate.
Thank you. Thank you. Okay, well, we'll get started. So I think we have a bunch of people online and then people will filter back in. I know both Neil and Renu fairly well, so I'm going to wing this introduction. Dr. Mehta will go first. He's an associate professor of medicine now at UCSF. And is basically the go-to person for hepatocellular carcinoma. Renu is his equivalent at Stanford with me, and also an expert in HCC. They will talk about changing approaches to hepatocellular carcinoma, or intermediate and advanced stage HCC. And I will just say, I'm glad this is not a debate style session because Renu last time gave Francis a run for his money. So Neil, you should be grateful.
Yes, I am. Thank you. Thanks, Allison. It's great to be here. Thank you for the invitation. And I always love talking about this topic, especially with Renu. So thanks. I'm just going to make sure this works. Okay, these are my disclosures. So as Allison mentioned, we'll talk about intermediates and locally advanced HCC first, and then the last 20 minutes we'll talk more about advanced HCC and the whole idea here is not to rehash what we already know, but talk about kind of what are the more recent advances in the field. We'll also talk about kind of some of the downstaging and all-comers outcomes in patients we're hoping to get to liver transplantation, and also briefly talk about kind of distinguishing portal vein tumor and bland thrombosis. So I wanted to start with a case of a 62-year-old patient with hepatitis C cirrhosis. This patient had a variceal bleed about 4 or 5 years ago, but has been doing well since, no ascites, no encephalopathy. They achieved SVR with DAA therapy a couple of years ago, but they were found to have on screening multifocal HCC involving both lobes. Total diameter of the tumors, there's about 4 tumors, all fairly small, but the total diameter is 9 centimeters. They appear to have a bland segmental portal vein thrombosis. The tumor itself, it hasn't spread outside the liver. The patient works full time, and you can see the patient's labs here. Bilirubin is mildly elevated at 1.5, same thing with the INR at 1.3, and the patient's MELD score is 12, and their AFP is 15. So when we think about staging HCC, there's a lot of different ways you can do it, and I just put a bunch of these systems on the left. We're obviously not going to go through all of them, but the one that kind of keeps coming up over and over again is the BCLC, and that's from Barcelona. And I just wanted to point out this one because they just updated, after many years, they just updated their staging system. But their staging system, and that's probably the one we most use for either research purposes or also sometimes for clinical purposes as well. It's a combination of liver function, tumor burden, and patient's performance status. So this is what it looks like. And so you can see on the left is where if you're going to get HCC, you want to be on the left. You want to be very early stage, small tumor, good liver function. And you have really all the treatment options, resection, ablation, versus as you move to the right, I don't know if my pointer is working. Oh, yes, not really. As you move to the right, you'll start to see more early stage. That's when we're thinking about resection or transplant. And Renu and I are going to focus on BCLC B and C patients, intermediate stage patients beyond Milan, or advanced stage patients who are either have macrovascular invasion or extrahepatic spread. So I just wanted to I just zoomed in a bit on the same staging system. So this patient that I showed you in this case has an intermediate stage tumor. They're beyond Milan criteria. They have four-ish nodules, but it's all confined to the liver. So we call that intermediate stage. And as you can see here, there's 3 different options we typically think about. You can think about local regional therapy, of which TACE is one of the main options. You can think about transplant, and I'm gonna, at the bottom, you see this concept of downstaging that the BCLC system is now added in the Journal of Hepatology this year. And then you can also, on the right, you can also think about systemic therapy for these patients as well. So we have to, as in our tumor boards, we have to decide what's the right way to go with these patients. So TACE, as a lot of you know, is a selective embolization of hepatic artery supply to the tumor via the common femoral artery. You can either do liquid TACE or DEB or drug-eluting bead, doxorubicin TACE. Patients can get kind of a post-embolization syndrome. You can, if you kind of taste the wrong thing, you can cause cholecystitis or abscess, decompensation, et cetera, but it's typically a safe procedure. But the new kid on the block that a lot of you have heard about is Y90 radioembolization, and that's done with these Y90 radiation microspheres, either glass or resin, and they have extremely high radiographic response rates. There's a clear survival benefit. That's level 1A data. There is a risk of radiation damage, so we do typically get kind of nuclear med planning studies to calculate your lung shunt fraction to make sure it's safe. But we do want patients to have relatively preserved liver function. So if their bilirubin is much over 2.5, we typically don't do Y90. There's only been one decently done trial. This was a randomized controlled trial published in Gastro 5-6 years ago that compared the two options. The problem is this was only at Northwestern, and they had a big time trouble enrolling. So they had huge plans to get many patients, but ultimately only could get 45 patients in this trial. But what they showed is that even in that small crew, that small cohort, Y90 performed much better than conventional TACE in terms of time to progression, meaning that patients who were randomized to Y90, their tumors seemed to responded much better than the patients who got conventional TACE. So that's all well and good and very exciting, but the problem here is that they showed no differences in intention to treat survival between the two arms. Very small study. We've tried multiple times to do a trial, a multi-center larger trial that would kind of replicate this and kind of confirm these findings or improve upon these findings, and we haven't been able to yet, but are still trying. But that's about the best data we have. So right now, we don't really prefer one option over another, typically. So that's a little bit about BCLC and kind of local regional therapy, but I want to move on to this patient. Ultimately, while you can offer TACE or Y90, these are treatments that likely can control disease, but won't cure disease. So when we think about curing this patient, really transplant's probably their only option. For someone beyond Milan criteria, which is the conventional transplant criteria, there's a whole bunch of expanded criteria. So the two I've highlighted are UCSF criteria and up to 7 criteria. But there's a few other options I mentioned here, but we don't really use these anymore for a lot of reasons. But one of the main ones is we're not allowed to in the US. You have to get exception points for transplant. You have to be within the Milan criteria. So if you're beyond that, it's really transplant is not really an option through normal means. But the other reason I put a big X through those two options is because tumor burden doesn't tell the whole story. If you just say, okay, I'm beyond Milan, but just barely, I'm within UCSF or whatever, like that's not good enough. Nowadays, we have to use other criteria to help us with transplant selection criteria. So these are, 10-ish criteria that have been proposed throughout the world. The ones on the bottom are used more in live donor transplant, but you can see that all of them combine tumor burden with some version of biomarkers. AFP is a common one. There's also something called DCP is a common one. And sometimes they'll even have additional criteria. And that's really the way the field is moving internationally to do better about picking patients for transplant. So I'm just going to pick one of these 10 systems just to give you an example of what it would entail. So this is the Metro Ticket 2.0 calculator published in Gastro 4 or 5 years ago. And what they do is you can see here that on the x-axis, it's a combination of your tumor burden. So the largest tumor plus how many tumors you have. And on the left, on the y-axis is your AFP. And so these are probably the two most common predictors of overall outcome is tumor burden and AFP. And so we plug this into our patient who has an AFP of 15. They have 4 tumors, the largest is 3 centimeters, and you can put your X on one of the lines, and so they would have an 85% expected survival, specific HCC tumor specific survival after transplant, which is pretty good. And a lot of centers in the world would actually be willing to transplant that patient right then. As I mentioned, in UCSF, we can't get access for exception points for priority for that patient. And so that's not an option here, but in another country, for example, they would actually do pretty well with transplant up front. A lot of countries actually don't have access to deceased donors, and so they do a lot of live donor transplants. And so I just highlighted another live donor selection criteria that was just published. And this one uses a combination of PET scan, AFP, and tumor burden as well. And so we could say, okay, our patient's AFP is under 100. That's good. Our patient is beyond UCSF expanded, so that's not good. you might use PET to kind of to split the difference to settle the outcome. And if they're PET negative, you might be okay with proceeding with live donor transplant. So these are ways that we can think about transplant in certain situations. But again, in the US, the standard way to go to transplant for someone beyond Milan is downstaging, because that's the only way to get them exception points. So downstaging is defined as a reduction in the size of tumor using these treatments, the TACEs and the Y90s, to meet acceptable liver transplant criteria. It's important to note that when you measure the tumors after treatment, you don't want to measure dead tumor. You only want to measure viable tumor. And we think of it as a selection tool for transplant. What I mean by that is, so say you have this patient with 4 tumors and you subject them to a TACE. In the next scan, the 2 tumors you treated are all dead. Well, that's great. That's exactly what we wanted. That seems like someone who has good biology and might do well with transplant. But what if you do the TACE and the next scan, actually there's another tumor that's popped up, or the tumor you treated has grown or didn't get treated at all? Well, that may not be as good, or the AFP rose. So downstaging itself is not only kind of necessary to get the patients to Milan, but is also a selection tool to pick the tumors that respond, and those patients likely will do well with transplant. So in the US, Milan remains the gold standard. We have to be within Milan to get exception points. We now have national criteria, standardized criteria, telling us which patients who are beyond Milan can be downstaged and get automatic MELD exception. So I put it here. You don't have to memorize it. You can just Google it. And so, for example, our patient is actually, even since they have 4 tumors and their total tumor burden is 9, they're actually beyond this criteria. But I did just want to go through this cohort really quickly. So this data kind of has evolved over the last 10 to 15 years, first at UCSF. This is a single center study showing no difference in post-transplant outcomes in patients who were downstaged compared to patients who were always within Milan criteria. We then took that one step forward. We combined efforts with Scripps and CPMC and published excellent 1 in 5 year survival after downstaging in a multi-center cohort. And then with that data, we had enough to basically go to the National Review Board and say, okay, this is something that we should be offering to all patients. And so now, if you meet these initial downstaging criteria, after downstaging, you can be automatically listed for transplant with MELD exception. You don't have to petition. No one can say no. It just goes through. So that's great. So the most recent thing we've done, and we've partnered with Renu and colleagues at Stanford, with Dr. Guy at CPMC and a lot of other centers throughout the country, is we've created a kind of a consortium. We call it Merits LT, a consortium of centers that are trying to understand downstaging outcomes nationally. And so far we have 209 patients meeting this UNOS downstaging criteria. And the first important point I want to point out is that no matter what you do, whether it's TACE or Y90 or other local regional treatments, your chance of getting a patient from the downstaging criteria to Milan is very, very high. It's almost 90%. So typically patients will respond really well to these treatments. We also didn't see any difference between TACE or Y90 as initial treatment. So going back to that earlier theme, so far we don't have any data yet that really says, okay, this patient should definitely get TACE. This patient should definitely get Y90. We're a little bit lacking on that data still. One of the important things to point out, and I know Renu and I have had these conversations, is even though we think they're downstage and they go to transplant, they still often have a lot of tumor on explant. And so that's one kind of piece that we still need to pay attention to, because we know the more tumor you have on explant, the worse your post-transplant outcomes are. So we do want to make sure that we're really continuing to treat patients up until transplant if they have viable tumor, as long as we think they'll tolerate it. So what if I take a step back and I'll remind you about this patient, this multifocal HCC. And again, total tumor diameter of 9 centimeters. So they're actually beyond downstaging criteria. There's something we call all comers criteria. So that's any number of tumors, but they still can have disease outside the liver or in the macrovasculature. The highlight of these next few slides is that those patients, as you might imagine, don't do as well. So this is intention to treat data. They don't do as well as a UNOS downstaging cohort. One important thing also to point out is the more tumor you have on imaging, the more number of lesions, the bigger the largest lesion is, the harder it is to downstage them. And that makes sense, right? If you have a 12 centimeter tumor, it's gonna be harder to get that patient to Milan than a 9 centimeter tumor. So this kind of makes sense. And so, sorry, just to go back. So our patient would be in this blue line. And so there's about a 70% chance that we think we could get them, at least initially, into Milan criteria. Now, we've looked at this data nationally, and it turns out that while the Milan and the downstaging cohorts do about the same after transplant, the all-comers do slightly worse. And so we do have to have our index of suspicion up a little bit for those patients because they aren't doing as well. So probably an upper limit of tumor burden exists beyond which successful transplant after downstaging is unlikely. The all-comers have higher rates of, or worse rates of downstaging. They have worse intention to treat survival. They have worse post-transplant survival. So what we've thought about doing for these patients is, what if we kind of try to make it easier for them? What if we actually try to add systemic therapy to see if we can improve their outcomes? And unfortunately, I don't have any data yet, but I think it is, this didn't turn out very well, sorry. But this is something it's a big workflow. I'm happy to share this with anyone. If just feel free to email me. And this is what we're doing. I think a lot of the other cohorts in the Merits LT consortium are doing this as well. And sorry, the font, it looks like the font got messed up a bit, so it may not be easy to follow. But if you email me, I'll send you a cleaner version of it. But basically the concept here is you take someone within all comers, you give them local regional treatment, you get them to the Milan, you list them for transplant, and then you put them on systemic therapy. You try to maintain them within Milan, so that you can actually get them to transplant. Renu is going to tell you all about the different new systemic therapy options that you might consider. And then you transplant them. And again, I have no data. We've just started doing this, but I think it is an interesting concept to explore. All right. So the other thing I want to highlight in this case is, what about I think this comes up for a lot of us, is what about the portal vein thrombosis? Is that tumor? Is it bland? I'm telling you it's bland, but how do we know that? So this is a study we did a few years ago with Dr. Courtney Sherman, who was at CPMC and now is at UCSF, who we basically got all the patients at UCSF transplanted, are listed for transplant over 8 years. And we said, okay, we split them up into 2 buckets: patients who did have a portal vein thrombosis and patients who didn't. And then we did a secondary kind of blinded independent radiographic review. And what we found is that there's 5 criteria that best predicts portal vein tumor thrombus. Okay, so very high AFP over 1,000, venous expansion of the portal vein, if the thrombus is actually enhancing, if there's neovascularity of the portal vein, and if the tumor is, you may have come up with this before, but if the tumor is actually contiguous with the portal vein thrombus. So they all kind of make sense. And what you can see here, that red line has a very high AUC, a C statistic of 0.97. So if you have 3 of those 5, we're pretty much guaranteed to have tumor thrombus. And so that's, sorry, I skipped the slide, but basically, and we like to use those criteria, and because if you do have tumor thrombus, your intention to treat survival is very, very poor. All right, in the last few minutes, I just wanted to shift gear. Well, what if we actually do confirm portal vein tumor thrombus? So now we're shifting gears a bit, and now I'll just say this patient's now will just give their AFP 150 instead of 15. So, Renu is going to talk a lot about advanced stage HCC, but there is this concept of locally advanced HCC. So locally meaning it's not outside the liver. It's just gone into like the portal vein, not the main portal vein, but like a branch or a segment of the portal vein. So we call that locally advanced HCC. And typically we think about systemic treatments, but that's not the only option. So again, she's going to go through all these. It's actually pretty interesting. Y90 and SBRT are actually really, really good options for locally advanced HCC. So don't forget, just because the tumor's gone into the right portal vein or the segment of the right portal vein, don't forget about local regional therapies, because there may be options here. So there is this concept of radiation segmentectomies that could have a role in portal vein invasion. There's been a couple trials that have looked at this. The SARA trial and the Survinib trial looked at Y90 versus sorafenib, and there was no difference in outcomes between the two. So there does seem like Y90 can have a effect on portal vein tumor thrombus. And now people actually started to look at this concept with transplants. In the past, we'd say, oh, they have portal vein tumor thrombus, we can never transplant them. But there's actually data that a subset can actually do okay, especially if their AFP is low. So I wanted to highlight this really recent study that was kind of intriguing. That was a pilot study done out of Italy, a single center, that applied Y90 for lobar or segmental portal vein tumor thrombus in 17 patients. They called it super downstaging. So what their goal was is they took these, you can picture these 17 patients. They all have portal vein tumor thrombus and they all got Y90. Okay, so that's the cohort. And what they said is, how many of them can we actually get their tumor to look dead, watch them for a while, and then transplant them? Because it's a cool concept, right? Because that's the only way to cure them. They also had to, their AAP had to be under 100. If they had tumor that was beyond Milan, that also had to be downstage. So there was a lot of things here, and only 30% actually were able to be transplanted. So the first take-home message is it's hard to do this. Okay, most patients aren't going to make it. The second problem is that of the 5 who got transplanted, 3 had pretty quick tumor recurrence, but 2 of those were able to have a pulmonary met resected. So in general, 15 out of the 17 failed this protocol. Either they couldn't get transplanted or they had tumor recurrence. And so kind of my take-home message from that is that this is something that's interesting to think about, but deserves a lot more study before we start transplanting people. At UCSF, if we have a portal vein tumor thrombus, we do the Y90. And again, this is not for main. Once you have main portal vein tumor thrombus, you go straight to systemic therapy. But if you have segmental, for example, we do the Y90. If the tumor all looks dead, you can then petition the National Review Board for points. And if you get it, we won't transplant them until almost at least 2 years from when their tumor first looks dead in the portal vein. So we want to do a long observation period. All right, so my time is almost up. So I just want to finish by summarizing that patients meeting UNOS downsaging criteria receive automatic listing priority. Okay, so that's important, especially for our fellows. So if you're in the UNOS downsaging, you get Y90 or TACE, you go to the Milan, automatic MELD exception approval. If you're beyond that criteria, if you're in the all-comers, you have to be very carefully selected for transplant because they don't do as well. You might want to keep doing local regional therapy. You might want to observe them for longer before transplant. You might even want to have more stringent AFP cutoffs. And then again, I mentioned this concept of maybe trying to combine local regional therapy with systemic therapy in that group to try to improve their outcomes. And then finally, we think that this AVENA criteria can help you distinguish bland from tumor portal vein thrombosis. For locally advanced Y90, don't just think about systemic therapy, but also think about Y90 radioembolization. But if you do that, even with sustained response after Y90, we're still a little nervous about subjecting these patients to transplant. We still need more data. All right, I think my time's up. So we're gonna shift gears and Renu is gonna chat with us about advanced therapies, systemic therapies, and then we'll do a little Q&A session. Thank you. Yeah. Oops, sorry. I think just if you exit. Can we get the new slide, the next slide set, please?
Okay. Hi, everyone. Thanks to the organizers for giving me this opportunity to talk about something I'm very excited about, the changing landscape of HCC management. So just an overview of my talk. I'll start with some background. I think Neil's covered a lot of ground there, so we'll sort of jump straight in to a timeline of the systemic therapies. I'll discuss immunotherapy in greater detail, touch upon some strategies on how we are sequencing treatment now, and highlight some challenges, future directions, and end with a few conclusions. So for background, this is data where on the x-axis you're showing 5-year survival for all cancers. You can see between 1970 and 2013, there's been tremendous progress. The 5-year survival is now, all cancers put together, gone from 50% to 67%. And for some cancers like breast cancer, colon cancer, there's been dramatic improvement in survival due to a combination of factors, early detection, better treatments. But look at liver cancer. It's one of the ones right at the bottom. We hadn't made much progress until recently. The overall 5-year survival for liver cancer, all stages put together, is still below 25%. So clearly there is a long way to go for this cancer. But there is a lot of hope and promise. And if you're wondering, are things changing? I would say follow the money. See where the investment is going in drug development. This is showing global liver cancer drug development market size in billions. And if I actually trace this graph backward for the last 10 years, you'll see that it's pretty close to the baseline. People just hadn't been investing in this cancer. But in the next 10 years, it's projected to reach at least $7 billion. So why and where are they investing? Of course, they are investing in targeted therapies, but a lot of investment and the huge amount of growth we are seeing is coming in immunotherapy. And the reason for this is some of the promising new developments and the hope that this will continue and we'll get a lot of new drugs into this market soon. So how, what is changing? What is going on? Why is there all this excitement and news out there? So again, to point out to what Neil had shown, this is a 2012 treatment algorithm by the BCLC stage, BCLC group. They usually, along with their staging, they show how to treat. And if you focus on the advanced stage, there was just sorafenib and best supportive care. And fast forward to 2022, this is their updated treatment algorithm, much more complicated. But again, if we focus on the advanced stage, in the bottom there, which we will expand now, you can see multiple options, first line, second line, switching over clinical trials. So there's just a lot of action happening in this field right now. The timeline, sorafenib was the first drug approved for HCC, systemic therapy for advanced HCC in 2007. It improved overall survival by around 3 months, from median survival of 7.9 to 10.7. And at this point, it was heralded as the dawn of a new era. But unfortunately, between 2007 and 2017, nothing much happened. A bunch of phase 3 trials failed, and sorafenib remained the mainstay, and it wasn't, improving survival a lot. But in the last 5 years, this graph here shows you the number of drugs that have been approved. Multiple tyrosine kinase inhibitors as second line, like regorafenib, cabozantinib, ramucirumab, lenvatinib in first line. And in the bottom here, you see all these immunotherapy options, nivolumab, pembrolizumab, and the combination in second line. And most recent approval, and which I'll talk about in more detail, is the bevacizumab, atezolizumab in first line. So all this has just happened in the last 5 years, and this year we are expecting more approvals. So clearly this has been a major change. So take a step back, just one slide on how immunotherapy works. So, that'll help you understand why this is all getting accelerated. So how do the immune checkpoint inhibitors work? A cancer cell evades the immune system by sending, if I may, a don't eat me signal. How does it do that? It expresses checkpoints like PD-L1, which engages with checkpoints like PD-1 or CTLA-4 on the immune cell, and think of it as applying brakes. So the cancer cell is going to apply brakes on the immune system and says, hey, don't eat me, I'm just going to grow. Now, what do we do with the checkpoint blockade? We are not targeting the cancer cell, which itself is a paradigm shift in how we think. All chemotherapy, targeted therapies try to attack and kill the cancer cell. Instead, all we are doing is removing the brakes. So just block PD-L1 or PD-1 or CTLA-4 or a bunch of other immune checkpoints. Now you allow the host immune system, the patient's own immune system, to attack the cancer cell. So that is why this is tolerated better. And you see these dramatic responses in some patients because now you're unleashing their own immune system. So when this was initially approved for melanoma, and I'm sure you saw a lot of news articles on how amazing this is, there was concern whether it would work in liver cancer for 2 reasons. One is the liver is an immune privileged organ. There's not a lot of active immune cells in the liver for important reasons. And second is a lot of patients have viral hepatitis. So now if you unleash this immune system, are you going to have more hepatitis? Are you going to have reactivation of the virus? So these were concerns. So the first phase 2 trial, which sort of addressed these main concerns, was the Checkmate 0.040. This in 2017 showed an overall response rate of 20%. Now, a lot of these clinical trials have multiple endpoints. I would say today I will focus on 2 endpoints. One is overall response rate. That's telling you whether the tumor is shrinking or not, and in what percentage. 2 is survival, which is self-explanatory. So the overall response rate was 20%. I highlight that because that was surprising and dramatic. Most of the tyrosine kinase inhibitors, usually the response rate is in single digits. The patient might have extended survival, but usually it controls the disease. It doesn't make the tumor shrink. Now, suddenly you were saying tumor shrinkage. And second thing, they compared viral and non-viral, and they found similar response rates. So it sounded like you weren't getting like active viral hepatitis or reactivation. So we could use this in this cancer. And this is the other very important point about immunotherapy. How long do people respond? In this trial, 59% of the patients who had a response responded for over 12 months. And a third of the patients had response for 24 months. So yes, only a subset respond, but those who respond can get these dramatic, durable responses, which is obviously, welcome. Based on this is only phase 2, mind you, but based on this promising data, FDA granted accelerated approval to nivolumab in 2017. And then we were all waiting for the phase 3 data, which did not live up to the expectation. So this is a phase 3 trial, nivolumab versus sorafenib head-to-head randomized controlled trial. The overall survival 16.4 months and did not reach statistical significance. But you can see in that survival curve that towards the tail, they appear to diverge. Similar fate for another immune checkpoint inhibitor, pembrolizumab, in this trial, Keynote 224. Pembrolizumab initially in the phase 2 trial showed a similar response rate of 18%, was promising. So in 2018, FDA granted approval to pembrolizumab in second line. However, the phase 3 trial of Keynote 2.240 did not meet the pre-specified p-value requirement. The overall survival was 13.9 months. And there was a tail effect. There was good response, but did not meet the criteria. So this is not first line. The third immunotherapy combination that was tried was, how about if we block 2 of these? Why just block 1? So let's just block both PD-L1 and CTLA-4. This was an open label phase 1/2 trial. Very exciting because the overall response rate is 33%. So now you're getting 1/3 of patients are having shrinkage of tumor. This is phase 2. But look at the arm A. The 3 arms are basically different dosing regimens. In arm A, they showed an overall survival, median overall survival of almost 2 years. So a lot of excitement, and you know the story by now. FDA granted accelerated approval for the combination, but this is the one combination which appears to at least meet its promise. The phase 3 data was just shown in the ASCO GI last week. So the paper is not out, it's just the press release and the abstract. I took a screenshot of that. This is the primary objective, overall survival. This is called T300 plus D because they are giving a single dose of the CTLA-4 inhibitor and then giving the PD-L1 inhibitor. And it did meet the primary endpoint, improvement in overall survival to 16.4 months. So this is the combination that we expect FDA might approve this year. I say might because there are some issues, and you can see the hazard ratio 0.78. That tells you that it wasn't as effective as initially expected. And there are a lot of autoimmune side effects if you unleash your immune system. So we are still waiting for the full study and then the FDA review. But this was studied as first line, and this is the first just immunotherapy combination that seems to work. But in general, I think the field is beginning and has been looking beyond single agent checkpoint blockade, because I've shown you this, the data that despite all the promise in first line, when you do it in the randomized setting, it's not always panned out. And the reason for this is trying to understand why we think a combination will be better. So if you look at these graphs here, these are hypothetical graphs on what happens with the different kinds of therapy. What you see in purple is chemotherapy. HCC, you can ignore that because it really doesn't respond to the traditional chemotherapy. And then you have targeted therapy in the blue. Green is the immune checkpoint, and orange is a combo. So what you see with immunotherapy, that's the green. A small subset respond, but then they respond for a long time. So you get that nice curve that goes like that. With targeted therapy, a significant subset respond, but they lose response and it bottoms out like that. So what we are hoping is if you combine both, you could get a larger number of patients to respond. And then with the help of immunotherapy, you could now maintain them in remission. So that is the reason there are tons of trials combining lenvatinib with immunotherapy, sorafenib with immunotherapy, or even chemoembolization with immunotherapy. And this promise, I would say, was met in this clinical trial, IMbrave 150, published in 2019, and then the approval came in 2020. This is 2 drugs, atezolizumab and bevacizumab. For ease, we will call it atezo-bev. Atezolizumab is a PD-L1 inhibitor, and bevacizumab is a VEGF-R2 inhibitor. So it's inhibiting a growth factor. So it's a targeted therapy combined with the immune checkpoint therapy for primary first-line therapy. So this clinical trial, they recruited 501 patients, randomized in a 2:1 fashion to either receive sorafenib or atezo-bev. And atezo-bev, overall median survival, 19.2 months. This is the highest we've seen. And you should look at the hazard ratio was 0.58. So almost a 40% reduction compared to sorafenib. And we've not had these dramatic results with the immunotherapy alone. And the combination had an overall response rate of 33% and a complete response rate of 10%. So 10% of patients are seeing complete shrinkage of their tumor. So these results were an NEJM, obviously celebrated. One of the concerns in our field has been about bevacizumab, because bevacizumab has been tried for HCC before, and there were case reports of these dramatic overt variceal bleeding leading to patient death. In this trial, what they did was everybody got an EGD within 6 months of starting the therapy, because you need to make sure they don't have active varices. If they have varices, they need to be treated, banded to obliteration before you treat with this. The adverse effects in the trial were pretty comparable between the two arms. You definitely see more hypertension, proteinuria with the atezo-bev combination. But as you all know, if anybody's seen their patients with sorafenib, it also leads to multiple side effects like diarrhea and skin rash. So overall, the adverse event, grade 3-4 adverse events were comparable between atezo-bev and sorafenib. And definitely in your clinical practice, if you're seeing that somebody might need this therapy, might be going for this, make sure they have an endoscopy and be ruled out varices. So if this was the most recent, I would say, systemic therapy approval, atezo-bev, and it has become the first line. So now this is a new problem the field has, which I think is a welcome problem. How do you sequence these therapies? Because now you have multiple second line and a couple of first line. So how do you approach this? This is a review we published last year on what approach we are taking at Stanford and some of the expert opinion. And this is bound to change if we get new approvals. So right now, first line therapy is atezo-bev, standard of care. The patient has to be Child-Pugh class A. So this is only for compensated patients, good performance status, and advanced stage HCC. Now, if they are not a candidate for immunotherapy for some reason, for example, post-transplant patients, we don't want to activate an immunosuppressed patient's immune system. If you're a post-transplant or other specific circumstances, you could consider first-line sorafenib or lenvatinib, because both of them are approved. Now, let's say you're Child-Pugh class B, or somehow you have a contraindication for lenvatinib or sorafenib. It is not ideal, but nivolumab still has the provisional approval in first line, so that is an option. We are decreasing the use of this approach. In the past, when we only had lenvatinib, we had a subset of patients who were on monotherapy as first line with immunotherapy. I would say predominantly now, you really want to try to get your patients on atezo-bev. So what happens if they cannot tolerate first line or they progress on first line therapy? Then you have multiple options. I've tried to color the TKIs, the targeted therapies in green, and the immunotherapy combinations in orange. I have surprisingly found a lot of patients even ask me whether they can do the immunotherapy because they read some news article on Jimmy Carter doing so well, or some press release. I mean, immunotherapy has just been advertised very well. So they ask me whether, and also the concept that it's their own immune system and that they're not taking a toxin, but they're just using their immune system. I think patients like it. So the second line options, I would say the ones that have been approved, you have lenvatinib, especially for sorafenib failures. Regorafenib has been shown to do provide survival benefit. Cabozantinib has also been shown to provide benefit in third line. So if they have failed atezo-bev and lenvatinib, then cabozantinib is an option. The combination immunotherapy, which currently is in second line, we are hoping will be first line. In that case, if there is a contraindication to atezo-bev, as in if they have uncontrolled varices, you could start with combination immunotherapy. And you still have the other two immunotherapies, nivolumab and pembrolizumab, available in second line, of course. And ramucirumab, this is the only biomarker stratified advanced HCC option, as in if you have a patient who has an alpha fetoprotein greater than 400, in this specific subset, ramucirumab has been approved. So if they fail the first line and their AFP is still high, that would be a great option to move to. So these are just, again, like expert opinion, things we put together. There's a lot more study needed on how we combine these different options. And a slide that I think I included, but eventually didn't make it to the final cut. In the ASCO GI, they did show that lenvatinib plus TACE was also offering benefit for intermediate stage HCC. And me and Neil have spoken about it on how this is all going to evolve. There's a lot of questions here. So what are some of these challenges and future directions? Where are we going with this? I would say I've just highlighted few I think are like burning questions and important areas that we need to address. Number one is to determine the utility and the sequence of these therapies, especially if you have early HCC and you want to do it post-transplant, post-resection, in these adjuvant settings, where do these therapies now play a role? And second thing is a pretty common challenge. All clinical trials have only included Child-Pugh class A, and I'm sure in your clinical practice, you're all treating a bunch of Child-Pugh class B. They just have ascites, mild decompensation. Where do they fit in? It's unlikely that there's going to be a large clinical trial for those patients. The data is going to come from real-world experience. There's also some data that lenvatinib or sorafenib is safe in Child-Pugh class B, and so does nivolumab. But it's an area that needs to be systematically studied, because these patients not just have cancer, right? They have underlying liver disease. And an area that I'm very passionate about is the biomarkers. We need to move towards precision medicine. If you look at lung cancer or breast cancer, there's very clear biomarker-driven approaches, ALK positive, HER2 positive, TRK positive. But in liver cancer, we are still just using the same treatment for all patients. So we need to identify these biomarkers, which can predict who's going to respond to which therapy. And the combinations of targeted therapies with ICI, obviously we have atezolizumab, but there's a lot of ongoing studies comparing lenvatinib or sorafenib with immunotherapy, and also locoregional therapy with immunotherapy. And we are already anecdotally doing some of these combinations in our practice, like lenvatinib plus TACE, and seeing that the patients are able to tolerate both. So this is really an exciting time because there's so much changing here. And of course, last but not the least, ultimately, we do need better therapies. Yes, we can take everything that's existing and combine it, but you saw it, we are reaching somewhere, we are looking at something like a 2-year survival of like 20%. I'm sure, you know, if we look at, I showed you the graph for the other cancers, we have a long way to go. And I do think a novel therapy would be a much better answer beyond just combining the different existing ones. So let me end with a few take-home points. The treatment landscape for HCC is rapidly changing. Immunotherapy is set to play a major role. Currently, atezolizumab combination is approved as first line, and nivolumab and pembrolizumab for second line use in the US. We expect that the combination of immunotherapy might get approved as first line this year. I didn't touch much upon this, but immune-related adverse effects are common with immunotherapy. And as hepatologists, gastroenterologists, even if the patient is getting immunotherapy for a different kind of cancer, they could develop autoimmune hepatitis. And we're going to see these patients more often with immune-related adverse events. And ultimately, a multidisciplinary team management will become the key to manage HCC, because it's not just the cancer being managed by the oncologist. We have to work closely with them to manage the underlying liver disease. Thank you.
Are we taking questions? Is that the plan? All right, I'm gonna try to figure out this works.
Thank you for the excellent talks, Neil and Renu. Neil, just wondering if you can comment on kind of how you think about living donor liver transplant in patients who undergo downstaging or are being considered under all comers.
Yeah, sure. So for those of you who couldn't hear, Nazar was asking about live donor transplant selection criteria. And so, there's a lot of different criteria that have been published. The one I kind of briefly showed included kind of 3 options. So tumor burden, AFP, and PET. And I think the nice thing about live donor transplant, so again, not a lot of this is done in the US, but in the US, I think even if someone has a live donor, we still take the downstaging approach, right? If you have a person with a 7-centimeter tumor and they have a live donor, often we still like to observe them for a little bit. And one of the best ways to do that is subject them to a TACE or Y90 and see their response, have some time to work up the donor, and then move forward, say after the post-treatment scan looks okay, their AFP is okay, then you move forward. So I think you can still use downstaging. I think that's the main approach, but you don't have to. And in a lot of countries, especially Korea, India, and a few others, they're going straight to transplant. And in that setting, you have to be a little bit more careful because you don't have the luxury of time or the looking at response to local regional therapy. So if you don't have those things, then the things we really like are PET scan. I think PET is somewhat underused for insurance reasons, but also you can do a PET the day before a live donor transplant, right? It all can be timed. And so PET, we're not talking about looking for extra hepatic disease. PET scan is actually looking at the tumor itself, especially the non-treated tumor, is it PET positive? And if so, how positive it is. So we don't just say it's positive, right? We don't just say the SUV is 3 and the background liver is 2.5. We look at that ratio. So the tumor to non-tumor ratio is very useful. And the higher that ratio, the more metabolically active the tumor is, the worse your post-transplant outcomes are. So that's why a lot of the staging system, a lot of the live donor selection criteria use PET positivity, because it's a really good predictor of post-transplant outcome. So, you know, the one I kind of pointed out was AP over 100, PET positive, and kind of beyond UCSF expanded criteria. So if you have, so basically you could say, okay, I have 3 of those, I have 2 of those, and then you can figure out how you're going to do. So I think in the US, we mostly do downstaging. We have luxury of time and response. But in other places, they often, if they're going to go straight to transplant, they use some of these more immediate markers, PET scan, AFP, and then there's also other biomarkers. The ones that have the most data are AFP-L3 and DCP. And so in that setting, we also can use those prognostic markers at the time. And the reason this comes up in kind of the US often is if someone's beyond Milan and they don't have exception, but either they do have a live donor or they actually have a native MELD of like 36, can we transplant them right away? And so we start to look at biomarkers, you know, NLR, all those other things. So that's kind of how we think about it.
Excellent series of talks. But, you know, I have actually 2 separate thoughts, you know, and the first one is that in the patients who are, you know, undergoing systemic therapy, you know, some of these, like this, some of the patients actually, you know, respond really, really well. Some don't. So, you know, that's why you have such a big difference in the graphs in some of these, you know, overall survival. So it'd be good to know, you know, like, you know, which of these patients are actually going to respond really well. And as you said, you are, and you have this interest in type of targeting treatment. So, you know, what are your thoughts of like why some patients respond so well and some don't? And is there a thought that we can actually take it to help these patients more like this, like better?
Yeah, excellent question. So for immunotherapy, at least, they've looked at it in other cancers, and the antigenicity of the tumor, how many new tumor antigens are there on the surface, because ultimately a tumor is still a part of the same host, right? So the body might not recognize it. Now, if you have a lot of tumor mutations, then you might be making new proteins, which can get recognized as foreign, and the immune system can attack that tumor. So the tumor mutational burden, TMB, they call it. So if you have high TMB, you're more likely to respond. So if you have microsatellite instability or the MSI high tumors, like in colorectal cancer, those are more likely to respond. So now beyond the tissue of origin, it's becoming like pan-cancer approval. If you have MSI high tumor, all of you can get immunotherapy. The problem with liver cancer is we do not biopsy liver cancer. So we don't have a great idea on, you know, what is the advanced HCC, what is the genetic makeup, what is the tumor microenvironment like. And in the TCGA study that we did, we studied it, but most of the HCC studies use resected samples, and those are BCLC-A small tumors. These large multifocal infiltrative tumors, we really don't have a good understanding, and we don't biopsy before and after. So there is this like black hole, right? So my lab, we focus on trying to find peripheral non-invasive biomarkers, because the field's not going to change so dramatically that everybody gets a biopsy. So we are looking at the peripheral immune system to see if there are certain immune subsets that are activated. And so we know that when we give immunotherapy, it might work better. So that's one approach we are taking. And ctDNA. So ctDNA is the circulating tumor DNA that's shed. And now you have a non-invasive way of measuring what kind of mutations might be there in the tumor. So another approach, instead of a biopsy, is this liquid biopsy. So now we can use the ctDNA mutation burden to predict. So if a patient has a ctDNA, multiple mutations, I think it's a pretty good indicator that they're going to respond. So these are all like in the early stages. I think they're developing. I'm pretty sure in the next few years we'll see that. But that's the question everyone's asking: who responds and why? So there's both tumor factors and the host factors. Younger patients with a more robust immune system are more likely to respond than older patients. There's differences between male and female. But like to get somewhere where we have a MELD score or a BCLC system or a MERITS LT, I mean the system that they have, or the VINA, like these kind of scoring systems come from robust underlying data, right? But we don't have the genomic and immune data, which is what we are focusing now.
Excellent, thank you. And I did want to make a point about actually making I do work a lot with PET scan, and I do have to say HCC is not it's actually not like this PET avid tumor, and that's very important to keep in mind as you make use of SUV. And we are trying to develop like this advanced methods so that we can actually detect it better. But do you really use it for clinical methods, and have you felt you have missed out HCCs which you could see on the CT scan, but it didn't pick up on the PET scan?
Yeah, it's a great point you bring up, and I think it's for the whole group is that HCCs are not typically seen on PET scan, so that's you definitely should not be using PET as part of kind of surveillance at all. But so the times we use it are either if we're really looking for metabolically active, because it's not typically PET positive. When it is, that actually becomes quite useful, I think. So we don't use it for surveillance, we only use it for prognostic purposes, such as like, how are they going to do a transplant? Or the other time we use it is if someone's AFP is rising and we can't find the tumor on the standard CT chest, abdomen, and pelvis, and there's no lymph nodes, there's no anything. Often we'll try to just kind of Hail Mary PET and see if anything is PET positive, because sometimes that'll be helpful. Those are the two main scenarios we use it.
You have one question from the online audience, and I'm pretty sure it's not a plant, but I saw an Oncogard booth out front. What is the role of Oncogard in your clinical practice? Is it diagnosis, prognosis, treatment management?
So the Oncogard, so they have published data as a biomarker for HCC. So biomarker studies, they all go through these phases, just like your clinical trials, 1, 2, 3, and randomized control trial. So in my practice, I'm waiting for more data before I make it a routine part of my like alpha fetoprotein or something. Where I see it, at least now, the way we are using it on a research sort of basis, is those patients who have indeterminate liver tumor and their AFP and AFPD3, AFPL3 and DCP are also not very helpful, and you're really suspecting this, then I think Oncogard right now, it's a tool that you could at least use, because you can go through the company and do it as a send out test. So I think we are using it in that setting right now. But this is like, today we spoke about the changing landscape of HCC management, but if we had to do the same thing as changing landscape of HCC diagnosis, I would say this would have been right on there, because it's really promising. There's just a lot of excitement that finally we have some liquid biopsy options, and we are able to look at these peripheral genomic biomarkers. I think protein biomarkers is what the field has studied for decades, and in other cancers, it's been shown great promise, both for detecting systemic disease, metastatic disease, residual disease. So I see a huge role potentially coming up in the future. But right now, this is how we are using it.
I totally agree. I would just add that, patients at risk for HCC, so patients with cirrhosis, bless you, and no, you're good. And in chronic Hep B, only about a quarter of those patients are actually getting kind of up-to-date HCC kind of screening. And so in that scenario, you can see a huge role for something like an Oncogard, which has good data that can basically revolutionize the field of kind of staging or kind of early detection. So I think it's very exciting. Hopefully there is also going to be a role in kind of management, but we're not there yet. But certainly we're a lot closer to a role, especially because there's a huge unmet need for most of the population that's not getting Q6-month ultrasounds.
Great, thank you both.
Thank you.
Thank you.
So next up,